The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hi, everyone. Welcome to all of you who are TMD warriors. We're here for the next episode of TMD Demystified, and I am Tony Urbanek. Welcome, welcome, welcome. Tonight, it is night. Had a little change in venue because today I did not have time during my busy day to tackle the next episode of TMD Demystified, so I'm doing it from my home office after I got home and doing a little extra homework. Please excuse my dishevelment, but I always don't wear a tie. A surprise. In any case, I have very exciting and good news as far as I'm concerned, and that is right before Christmas, I received by email from the author the final draft of the two academic studies that were written out of the white paper material that I've discussed a little bit in the past on past episodes. Those two studies are now available and have been sent out to two separate journals for peer review and completion for publication. This is pretty exciting for me and all the people that helped me to get together and proceed with this study, which I must mention it was an independent study that I supported, commissioned through Middle Tennessee State University and the entire academic process. But I am going to unpack these studies, two separate studies, gradually over a period of time. And tonight, the title of this episode will be something like Study Results, Tinnitus, Subjective Hearing Loss, and Vertigo Dizziness. We're going to just concentrate on those three symptoms as they apply to the study, the findings, why that's important, how that will play off in the future for those that are involved using the device and protocol for their patients. So the study, there are two separate studies, and the way this was organized is one study, which is entitled, I'll need to read this to you, Individual Benefits of a New Method for Treatment for Temporomandibular Joint Disorders. That study has been submitted to Health Services Review. And the second study, entitled Work Distraction, Employer Cost of Preventable Joint Disorders and Implication for Business. We'll unpack that much later on. And that has been submitted to American Business Review. And there's reasons why those journals were selected as we roll out the findings of my 10-year work on this project using a non-surgical intraoral device for the treatment of temporomandibular joint disease, along with appropriate protocol. But the first study that's been submitted to Health Services Review had actually, and that's why I'm picking this first, had some surprising findings for me. I knew the findings would be good. I think the good findings are excellent, but the findings of the analysis and statistical analysis based on our 3,000 patients, which came down to surveys that were sent out and 257 usable respondents, surprised me positively when it came to the results regarding these three particular symptoms, which is very meaningful as I develop the usefulness of this device along with my team and develop network providers, of which, if you are watching this, you may be already a network provider, or you may be interested in becoming a network provider, which I encourage you to do. There's a lot more information, and these studies that I reference and the materials and findings within the study, I think are very significant. So just a brief review. I've touched on the white paper these studies are based on before, but just as a brief review, this particular study, the first one, individual benefits of a new method for treatment of temporomandibular joint disorders, partially the results included three aspects. Number one, the effectiveness of the device and protocol on symptoms, the effectiveness of the device and protocol on quality of life interference. In other words, the reduction in interference with quality of life if you have these symptoms. Another way of saying that is how much is your quality of life improved. But the corollary that was in the study is specified as effectiveness, quality of life, interference, reduction. And then the third part is effectiveness of reducing the cost of temporomandibular joint disorder, decrease in the treatment cost of temporomandibular joint disorder. And that will be left for a different time. So regarding the effectiveness, that's what we're going to talk about tonight. And I'll try to make it, as always, as brief as possible, meaningful as possible. These three symptoms, tinnitus, subjective hearing loss, and vertigo, dizziness. Now, vertigo and dizziness are actually separate symptoms. I've looked it up, read up on it a little bit. Let's start out with vertigo. Vertigo is considered a symptom of frequent and recurring dizziness. Frequent and recurring, almost predictable, would be considered vertigo, because I myself wanted to know, what is the difference between dizziness and vertigo? And the study was cranked into the study as separate symptoms, and we'll talk about that in a little bit. And they are different. They are defined a little differently. So frequent and recurring, almost predictable, and constant is vertigo, where intermittent and not so predictable would be considered dizziness. Well, so we'll just leave it at that. And so, but we will separate those two symptoms out in my discussion. But the entire symptom list that was in the study, I just wanted to go over this. And basically what I'm reading from is the page that elicits the tables of the decrease in symptoms according to the patients, their survey answers, their decrease in symptoms for each and every one of the symptoms that were noted associated with TMD. So the symptoms in the study that were routinely associated and well accepted with TMD are listed, except one. The last one is not so much an accepted symptom of TMD, but it was intentionally put in the study because I wanted to try to make a distinction, see if we could come up with some information, some statistical information, having to do with how often patients with TMD have the symptom of visual disturbances, which almost exclusively separates TMD symptoms, accepted TMD symptoms, with migraine headaches. Migraine headaches are almost exclusively defined in the literature, in the accepted papers, of symptoms that frequently and almost always also have an association with visual disturbances. Of course, I have seen in hundreds of TMD patients who have verified inflammation within the temporomandibular joint by examination and history, but primarily examination. Oh, it hurts, the joint's inflamed. That also have visual disturbances which resolve with treatment of the inflammation within the joint. So the claims there are muddy at best right now, but that's the last symptom I'm going to read, and hopefully we will unpack that a little later on at a different episode. I'd like to do that. And also I want to say that this study is not, it's a standalone study. Both studies are standalone studies based on a lot of quantitative information, but it isn't the final word. There are, as I think about this, there are many additional studies which can and should be done on all of these aspects of TMD. One of the ones that I plan on doing, hopefully in the near future, relatively near future, as circumstances and other things permit, mainly resources, is to do a very simple study and distinguish the number of patients who have qualified, diagnosed migraine headaches that also have inflammation within the joint. And when you relieve the temporomandibular joint inflammation, their migraines go away. That study can be put together fairly simply, prospectively, in having two groups. Both of them have been treated for migraine headaches, been diagnosed with migraine headaches. One group not treated with the device and protocol, and the other treated with the device and protocol. See where it flows out. See where the penny drops. I want to do that study. That's a very important study. In any case, the symptoms that this study addresses on a symptom by symptom basis, and indicating what percentage of those symptoms statistically are decreased for this respondent group, which is 257 respondents. Those symptom lists include headache, jaw pain or jaw tension, limited mouth opening, jaw popping, jaw locking, pain with chewing, clenching or grinding of teeth, neck which clenching and grinding of teeth is not really a symptom, it's an affect. But actually, I did not pick out these symptoms, by the way. The study developer, at my suggestion, totally developed this study from whole cloth. I did not have anything to do with designing the study, picking the questions, anything to do with it. It's totally independent. So that kind of snuck in there, that symptom of clenching and grinding. It's really not a symptom. It's neck and shoulder pain, waking at night due to headache, jaw pain, or neck pain, headache, jaw pain, neck pain while sitting, ear pain, ear ringing, tinnitus, subjective hearing loss, or fullness in the ears. Most patients describe that symptom as my ears are full, like I'm in an airplane, or I can't hear, like I've been swimming and can't clear my ears. Dizziness, separate symptom, vertigo, recurring dizziness, constant dizziness. Shoulder pain, upper arm pain, arm, hand, finger tingling and numbness, and visual disturbances. Those are the symptoms that are addressed in this study. Tonight, we're only going to talk about 3 of those. And those are actually 4 of them: tinnitus, subjective hearing loss, vertigo, and dizziness, because they came out separately, separate descriptions and separate statistics. They were all pretty similar. So let me just go through a little bit of the design of the study based on these 257 patients. All came from my 3,000, more than 3,000 cases out of my own practice. The study was divided in both papers, divided into two groups. Group one are patients who had prior TMD treatment of any kind. If they said during the survey, written survey, that they had any kind of prior treatment, chiropractic, surgery, different kinds of surgery, license and lavage, medical treatment, drugs, they were thrown into the group of had prior treatment and prior diagnosis of TMD with prior treatment. The second group had no prior treatment. They may even have had the diagnosis of TMD prior to entering my practice, but they had no prior treatment at all, according to their history. And the numbers in those two groups were fairly similar as it worked out. They were roughly similar. I don't remember exactly. I don't have that information right before me, but I remember they were about the same. So they were comparable. So here are the findings based on these 257 patients, and what the statistics showed were the decreases of each one of those symptoms for the two groups. So group one, patients that had prior TMD treatment of any kind or multiple treatments for that matter. They may have had surgery, they may be on drugs, they may have been chiropractic, they may have been doing physical therapy, multiple physical therapy appointments, multiple chiropractic appointments. But after treatment with the urbanic device and protocol, the symptom of tinnitus for those who had prior treatment decreased 46%. Those that had history of subjective hearing loss, 56%. Those with a history of dizziness, 66%, and those with history of vertigo, 67%. Decrease in their symptoms statistically for the group. For those that had no prior treatment, tinnitus had a decrease of 50%, subjective hearing loss 64%, dizziness 71%, and vertigo 75%. Now, a couple comments I'd like to make on those statistical numbers based on statistical analysis, which are in the paper. The paper is available for anybody. If you don't already have a copy, give us an email, give us a text. We'll send you a copy of both papers. Number one, it does not surprise me that out of that symptom list, the tinnitus is the one that had the least response. Actually, it's a pretty good response. If you can decrease 50% of the tinnitus that a patient has experience, that's a huge number when it comes to tinnitus, because my ENT colleagues struggle with that tremendously. But the point I want to make about that number being the lowest of that group is this. What I have found is that tinnitus is always the last symptom to diminish and go and leave, if it's going to leave at all. I do not claim that we can treat successfully all cases of tinnitus. I won't do that. I don't need to do that. This was a good statistical study, a real study, scientific study. And it showed that of those two groups, group one, 46% decrease in tinnitus and the other 50%. But what I know is that some of those patients responding may not have been using the device long enough to get the maximum benefit, because I have seen in the group that I treat, of those 3,000 plus patients that I've treated over the past 7 years, tinnitus sometimes takes 6 months, 8 months, a year, sometimes a little longer before the patient will start seeing decrease in the tinnitus symptoms, which are varied. And I have multiple examples of that, but examples aren't a scientific study. So, that's why we did the scientific study and analysis. So that doesn't surprise me at all. And it may, on further studies, I mean, this study is complete, but on further studies and further massage of how a similar study is done, knowing how far the patient went out into the use of the protocol, which is using it 24/7 for on average 2 months, and then going nighttime only for indefinitely, that the numbers for tinnitus may have even improved more than that, But I take 50% as a huge win, especially when ENT doctors just scratch their head and shake their head, roll their eyes, and all these thousands, hundreds of thousands of patients come into their office with chronic tinnitus, and the ENT doctors don't have anything to offer them. True. Subjective hearing loss, of the three, that is the symptom that were described at 60 of the two groups, 65 and 64% decrease in symptoms. By my experience with a lot of patients, subjective hearing loss of those four symptoms is the one that goes away soonest. So the percentage that's indicated here is 65 and 64%. And I would expect those patients to experience that symptom to be resolved, level of symptoms to resolve sooner rather than later. And then dizziness, 66% and 71% of the two groups, and vertigo, 67% and 75% decrease of the two groups, respectively, are again significant improvement in those symptoms. And the statistical analysis, the P was equal to 0.01. It's in the study, academic statistical study. P was 0.01 on these symptoms, which is highly significant statistic as it's analyzed. So what does this mean? I mean, that's these numbers, those of everything that I read in the study. I didn't have any really surprises, except that I was pleased. I was really happy to see everything was validated. We'll talk about all those things later on. I mean, just for example, headaches, the percentage decrease in symptoms of headache was of those two groups, both of them were identical, 63% in both the groups that had prior treatment and that had no prior treatment. But we'll go through those other symptoms at a different time. But all of the symptoms showed similar findings or better than these four symptoms we're discussing now. But these surprised me because I had told all my patients that, and quote, ringing, fullness, and dizziness work through a separate mechanism. And as I've discussed on prior episodes, that mechanism is the ability of inflammatory fluids and exudates to travel up the petrotympanic fissure, which is a highway from the glenoid fossa into the middle ear. Literally, it's anatomically described as a potential avenue into the middle ear from the glenoid fossa. It's like, why isn't that taught in dental school? Why isn't it exclusively on the list of things that anybody who treats temporomandibular joint academically needs to be aware of and function with? It's not. I know it's not. It's not in the textbooks. It is in the anatomy books, And actually, there are other papers that I did not write with this, which describe that anatomical finding. Petrotympanic fissure, look it up. Get out your Gray's Anatomy. Well, what that means is that there is a lot of opportunity for dentists, oral surgeons, orthodontists to use this information that we as dental professionals can help our ENT colleagues treat these symptoms. That's what it boils down to. And it's only making them aware enough that it is available and it is statistically successful that they will then appropriately refer patients with these 4 symptoms, tinnitus, subjective hearing loss, dizziness, and vertigo, to the dental professional practice. Because unless the ENT doctors, and maybe some practices will, hire a dentist to actually treat those patients appropriately by decreasing inflammation within the joint using the urbanic device and protocol, and that's possible. ENT practice, large practices that might have 4 or 5 or 8 ENT doctors and a couple, 2 or 3 audiologists may want to invest in hiring a dentist to do the device, use the device protocol, do the follow-up correctly, and get the response on these 4 symptoms. That may happen. But for the most part, I don't expect that to be the greater part. I think the greater part will be to make our ENT colleagues aware that these findings are available and the success is available and the referral line is available to refer them into your office. So with that explanation and that description of these symptoms, which are new to me, pretty exciting when you look at it, as to the opportunity for you, the individual doctor who uses the device and protocol, to expand their practice to help huge numbers of additional patients in an area that has not been open for the dental profession in this specific set of symptoms at all. Opens up significantly. So I made my point. I think I'd love to hear comments or questions, as always. And I encourage those that are not already network providers for TMJ services, the urbanic device and protocol, to get involved. And email us, text us, call us up. You can address us through the website, www.tmjservices.net. You can contact me directly at tony@tmjservices.net. You can contact our Director of Education and Marketing, Naomi, at tmjservices.net. I, as always, appreciate your attention, and I very much look forward to the next opportunity I have to talk with you. And hopefully I will be able to keep up with my schedule a little better. I had just a really busy day today, and I'll have my tie on again and be back at my usual venue, sitting at my office desk rather than my home office. Thank you very much for your attention, and I look forward to speaking with you at the next episode of TMD Demystified.